another knowledge-filled episode of MedSynapse podcast series. I'm your host, Hetvisha, and today we're tackling a topic that is very common but might have many underlying causes, which is headaches. From debilitating the migraines that can disrupt daily life to more common tension headaches that many of us experience. And understanding these conditions is crucial for effective management. And to help us decode these headaches, we are joined by Dr. Varun Kodam, a distinguished neurophysician who is currently a consultant neurologist at TX Hospitals at Banjara Hills. Previously, he was an assistant professor of neurology at Nizam Institute of Medical Science in Hyderabad. Dr. Varun specializes in stroke, epilepsy, headache, and other brain and spine-related diseases. So thank you, Dr. Varun, for joining us today. It is a pleasure to have you with us.
Yeah, pleasure is mine. Thank you so much for the invitation. And I'm very glad to join the program today. Yeah, myself, I'm Dr. Varun Kodam. I did my DM in neurology from Nizam's Institute of Hyderabad, Nizam's Institute of Medical Sciences, Hyderabad. And later I worked as assistant professor there. And recently I started my private practice at TX Hospitals, Banjara Hills. And my special interests are in headache disorders, stroke, epilepsy. So these are my interests.
Okay, so now let's dive right into our discussion. What are
Sure.
the common types of headaches you see in your clinical practice?
Okay, so headache is the most common problem we encounter every day. Almost 30 to 40% of the OP I see every day are with headaches. Okay, so I'm sure that every one of us must have encountered it at some part of our life. Okay, so there are different kinds of classifications for headache. The thing is, the recent one is International Classification of Headache Disorders, ICHD-3 classification, and they classified headaches into primary headaches, secondary headaches, and cranial neuralgias. So how we distinguish these things is primary headache, that means there is nothing abnormal except for the headache. Okay, so you do all the tests and you investigate the patient, but you won't be getting anything abnormal. But the patient will have headache. That is called primary headache. And coming to the next category, secondary headaches. Secondary headaches are those which are due to some underlying brain abnormalities, just like some tumors in the brain, increased pressure in the brain, that what we call as idiopathic intracranial hypertension, head injuries. Okay, so headache due to some infections. All these things are called as secondary headaches. And the third category is called cranial neuralgias. So one of the common cranial neuralgia we see is trigeminal neuralgia. Okay, so there are other cranial neuralgias like glossopharyngeal neuralgias. So all these things. So this is the third category. So what we commonly see is, so our main goal is to distinguish between whether the headache is primary or is it due to secondary, or is it secondary to some other disorder. So the common primary headaches we encounter are migraines, tension type headaches, and there is one more category called trigeminal autonomic cephalalgias like cluster headaches, hemicrania continua, paroxysmal hemicrania. So there are multiple different types of headaches, primary headaches. Yes.
Yes, right. And
Hope I'm clear.
Yes, you are very clear. And also identifying these headaches is also very essential, I think.
Yes, true. That makes a lot of difference to the treatment.
Yeah. Also, now can you tell us, is it common for a patient to have a multiple type of headaches like whatever you mentioned?
Yeah, it's very common actually. So most of the patients, they'll have different types of headaches. So the commonest combination being migraine along with tension type headaches.
Yes.
So, I mean, if patient has different type of primary headaches, that might not be a major problem. But if patient has primary headache along with a secondary headache, then that will be very challenging, because that will be changing the entire course of treatment.
Yes, right. Now, moving ahead, can you tell us, given the significant overlap in the symptoms between tension type headache and migraines, what are the key clinical characteristics you focus on to differentiate between the two during an initial patient assessment?
Yeah, so these are the most common primary headaches we encounter. Okay, so comparing between migraine and tension type headache, the most common one is tension type headache. But the patients coming to our clinics, they'll be mostly suffering from migraines, because tension type headache won't be that severe, urging the patient to go to a doctor. Okay, so those will be little infrequent, and those are not that severe, which impairs their day-to-day routines. But the migraine, it will be like some patients, they do even think they have some tumors or something seriously abnormal with them. So migraine is the headache which brings patient to consult some doctor. Okay, so there are few things which can be differentiating both the things. So migraine is relatively seen in more younger population compared to the tension type headache patients, and the characteristics of the headache is the most important. Okay, so let's say migraine, it is usually hemicranial in the sense that headache happens only on one side. They feel the pain only on one side of it, and usually that side will be alternating, sometimes on the right, sometimes on the left, and there will be associated symptoms like nausea, vomitings, photophobia, phonophobia. All these things will be there. Okay, and the duration of the headache will be longer, more than 4 hours. So most commonly patients complain of half a day to 1 day headache. So that is how migraine. It might last even longer. There are some entities like status migrainosis which last even more for more than 72 hours. Okay, so that is how the common migraine patients come to us. And coming to the tension type headache, it is relatively milder compared to the migraine headache. It is kind of the character is also important. Migraine is like throbbing headache. It's like pulsating. I mean, the patient will feel as if someone is hitting with a hammer on their head. That is how a migraine patient feels. Whereas tension type headache, it will be more of some pressing palsy, and it won't be as severe as even migraine. And it will be usually holocranial. That means it occurs in the whole of the head. Okay, and coming to the treatment strategies, migraine patients, they need, in routine practice, what we see is migraine patients need more higher level of analgesics like NSAIDs or triptans, and there are newer drugs like ditans. There are multiple newer drugs also. So migraine patients needs all these analgesics with little higher potential. But whereas tension type headache, some patients, they do even well just with paracetamol, which is a commonly used over-the-counter drug. Okay, so, and the prophylactic strategies also, the preventive strategies also, there is little variation. Okay, so, but there is some overlap. Okay, so migraine patients, there we can use multiple drugs like beta blockers, anti-epileptic drugs, tricyclic antidepressants. But and in TTH, I mean tension type headache, the most commonly used preventive medication is tricyclic antidepressant like amitriptyline. So these are some of the differences in migraine and tension type headache.
Yes, so identifying these are also important because they have
Yes,
a lot of common symptoms are there.
Yes.
Yes. So now, what is your strategy in treating patients with headaches, if you could tell us?
Okay. So the most, diagnosis will be told by the patient himself, him or herself. Okay. So listen, the most important thing is listen to your patient properly. Okay. So that gives the diagnosis. Okay. So any patient, if presenting with a hemicranial throbbing headache, which is unilateral and associated with this nausea, vomiting, photophobia, if all these symptoms are present, or at least two of them are present, then I treat it most like migraine. Okay, and if the headache, so just in routine teachings, what we say is tension type is headache is characterless headache. That means there won't be any specific characters. Only either they can have one of the associated symptom like nausea, photophobia. Any one can be present, but not all of them. Okay, so I usually identify both whether patient has migraine or tension type headache, or some patients do even come with both the types of headaches. Okay, so first identifying whether it is single disorder or both the disorders in the same patient. Then I choose I categorize them based on the duration, whether it's acute headaches, chronic or subacute. Okay, so usually acute headaches, we need to rule out the secondary causes. But the chronic headaches most likely are primary headaches. But we should be very cautious in labeling them as primary headaches. We should rule out all the secondary causes. So, and one of the most important clinical examination which clinches the diagnosis is examining for the fundus and blood pressure. These are the common things which are missed by most of the practitioners. So these will help us in identifying if there is any secondary causes. And I ask them for the frequency of the attacks. If the frequency of attacks is more than 1 per week, or if it's more than 4 per month, then I usually recommend them a prophylactic agent. So the most common, we can choose those drugs depending on the patient's profile. Let's say some younger patients without any asthma or cardiac illness, we can go with beta blockers like propranolol, metoprolol, which most of the patients tolerate well. So if obesity is a problem and the patient is not a female, we can use drugs like topiramate also, if there is no renal calculi or eye-related issues in the past. So depending on the patient's profile, I choose a prophylactic agent.
Yes, thank you for highlighting that. Now let's talk about a management part. So in terms of pharmacological management, what are the latest advancements in migraine-specific treatments such as CGRP inhibitors?
Right. So migraine is one of the common, so there's a lot of ongoing research right now. So CGRP inhibitors are one of the latest modality. Okay. So there are monoclonal antibodies which are against the CGRP receptors like erinumab, galcanezumab, all these things are there. So they are good preventive medications. Okay. But we need more data. Those are being used. We need to see how the patients, how is it going to be in the future? Because all this we have to analyze the data we are having right now, we are getting right now. Okay. And there are some other drugs like Rimijapan, which act against the CGRP receptors. These are CGRP receptor antagonists. Okay. And one more modality which is promising, which has shown promising results in the recent times is neuromodulation. These are the non-pharmacological therapies. So like non-invasive vagal nerve stimulation. So that device is called gamma core, and there is transcranial migraine magnetic stimulation, and the brand name is and there are some other modalities like peripheral electrical stimulation, Nerivio. It is being it has an FDA clearance for acute treatment of migraine. So there is a lot of promising research in terms of neuromodulation. So this is one of the newer modality, and we need more data.
Definitely. And these are some promising imaging techniques or research that is happening. Now, can you discuss the unique challenges of managing headaches in special populations such as pregnant women, and how do treatment strategies differ in these groups?
Yes. So when coming to the headache treatment of headache in patients, I think we need to be more cautious in treating younger women who are in childbearing group, because there are multiple drugs, prophylactic drugs, which are teratogenic. Okay, so drugs like valproate, topiramate, which are good prophylactic agents, are seriously teratogenic. Okay, so these kind of drugs should be avoided. So it's always better to limit the number of medications in any patients with pregnancy or breastfeeding. So there are some drugs. Usually what I do is I advise my patients who are pregnant or breastfeeding to take either paracetamol or ibuprofen, which are relatively safer. And coming to the prophylaxis, I advise, if prophylaxis is mandatory as per the patient's clinical profile, then I usually use beta blockers like propranolol or magnesium, which are relatively safer in these group of patients. So whenever we are starting prophylactic agents, it's always discuss with the patient. It's always better to discuss with the patient regarding the possible teratogenic, especially in the childbearing age group, younger women, because these disorders are commonly seen in that age group. Yes.
So they have certain side effects as well.
Yes.
Okay.
So teratogenicity, that is a scale.
Lastly, if you could share some case experiences where a multi-faceted approach was required to diagnose and treat a headache disorder?
Right. So coming to my experiences in the past, so usually I tell my juniors regarding two patients. So the clinical picture can be misleading sometimes. So you should be more cautious. So these two cases, patients were presented like primary headaches, but careful follow-up revealed them to have some other kind of headaches. So coming to one patient, she's a young lady, and she has characteristic unilateral throbbing headache with nausea, vomiting, and photophobia. Okay, and her frequency of attacks was around 5 per month. So I have a habit of checking fundus, blood pressure every time. So I checked them, everything was fine. I counseled her, I started her on prophylactic medication. She did well out. So around 1 year later, she came back to me. She said that she had worsening of her headaches. And when I closely inquired, there was a little change in the character of the headache. So I felt like reevaluating the patient. So when I checked the fundus, there was evidence of papilledema. So that means, when there is papilledema, that indicates that there is a raised intracranial pressure. That can be due to multiple causes. Then I asked for an lumbar puncture measuring the CSF opening pressure. The CSF opening pressure was around 35, which is very high. Okay, so this patient, though she had a primary headache in the past, careful follow-up. The main clinching points in this patient is changing character of headache and increasing the frequency of headache. So then I started her on acetazolamide and then she did well. Her headaches came down. So, I mean, it's always if a patient doesn't respond, or if a patient stops responding to the previous treatment, then it's always better to look at the diagnosis. Look back at your diagnosis. So that is one more.
Yes, rightly said. So looking
Yeah.
out for the symptoms, small symptoms is necessary.
Yes.
Yes. So that concludes our episode today. And thank you
Right.
so much, Dr. Varun, for sharing your insights and
My pleasure.
experiences with us.
My
today.
pleasure.
And I know headaches can be complex and challenging issue, but with the right knowledge and approach, they can be effectively managed.
Yes. 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 True.
Thank you so much for joining us today.
My pleasure.
And to our listeners, thank you for tuning into another episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, don't hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource. It's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. And until next time, stay tuned for more such enlightening discussions. Take care.